So I am here today of continuing this zigzag for safety all the way from Southern California to Capitol Hill, and along the way meeting with people who are really steeped in giving, receiving, and supporting and witnessing
Mm.
medical care, with a particular eye on making sure that we're prioritizing safety in doing so in all those roles. And I am really glad to be joined today by Carrie Buckner, who is a chaplain at Kaiser Permanente San Leandro Medical Center just outside of Oakland. Carrie, thank you so much for being here today, and I'm really looking forward to
Thank
our
you.
conversation. I appreciate your willingness to let
Thank you,
me record
Vonda.
this and post it. You're certainly
Absolutely. Thank you, Vonda. I'm happy to be part of this project.
great. I also want to say that you're co-chairing a group called the Kaiser Permanente Northern California Spiritual Care Peer Group.
Mhm.
That group is really attentive to 51 chaplains who serve that Northern California area through Kaiser.
Yeah.
And, when I started this extraordinary sort of journey all the way to Capitol Hill, intending to speak with people so that when I go to speak with legislators, I'm not just speaking from my own perspective or our family's perspective, but that I can really be well-rounded and hearing from many perspectives. One of the roles that I really wanted to attend to and hear from were exactly what you're doing. They're
Mm.
spiritual advisors, in your case, a
Yeah.
chaplain,
Mhm.
because you have this really unique position of being in care for patients and their family members, and also for caregivers. And I think maybe more than any other time that I've seen, at least in my very short 7 years of paying attention to safety in medical care, this has been a time when I think we really understand how critically important it is to care for everyone who is involved in the delivery and the receiving of healthcare. So it's
Yes.
particularly timely.
Yes.
Tell us a little bit about your role and what do you do? What does
Mhm.
a typical day look like for you in your role?
Well, a typical day, currently now in the pandemic, we're providing a lot of telephonic and video support for our patients, of course, but also for their family members who, for the safety of our public health and our public safety, are not able to come into the hospital. This has been just a huge stressor for so many families and patients who would normally be present with their loved one in the hospital 24 hours a day in some cases. So we, I just made a call right before this to a woman whose husband is in the hospital, and I mean, they've been married 64 years. She is, it's very distressing for her to not be able to be with him. He needs his glasses. He has problems operating his own phone. Their adult children are distressed that they can't also be with them. So I'm calling people, listening to their concerns, normalizing their feelings and emotional reactions for this particular family. They have a deep religious faith, and so they asked me to pray for them, which I did on the phone, and she asked me to call back. So a lot of the support we're doing right now with patients and families is by phone and video, and in some cases facilitating those video visits, because that is so meaningful just for family to be able to get their eyes on their loved one is just huge. And then also, rounding on staff, going up to the units, checking in with nurses, going to their daily huddles to offer words of encouragement, to laugh. We have gratitude jars in our staff waiting rooms right now. We're trying to really do as much as we can to create an environment that builds resilience for our frontline staff, for our EVS workers, for our respiratory therapists, our nurses, our doctors, the social workers. really little things go a very long way right now. So sometimes just, a pat on the back, or, saying to someone, hey, how did you celebrate Mother's Day? Or, thank you for being here, just offering a kind word, a smile. It really means a lot, because, everybody, all of us are holding a lot in this time.
You know, when the COVID first started to
Mm.
become so evident here in the United States, one of my closest friends' husbands went in for an emergency procedure, came home that day. I, with my mask on, helped drive him from about an hour south of Temecula back to his home. And overnight, he had another emergency, and it required them to go to the local hospital, where she was
Mm.
stopped at the door. This is an all too familiar story that we know of today. But what I want to skip to is that, of course, she called me because she knows that I'm very interested, and unfortunately, or fortunately, however you want to look at it, it has upsides and downsides, right? How I got here is not so fortunate, but that I am here is certainly my uh, my gift to offer and serve. It never would have occurred to me to call a chaplain of that hospital. So I just want you to know that already, in meeting you and having our conversation last week, and then just hearing what you said just now, I hope that people will really take to heart that the hospitalist is certainly somebody that we would typically think of to call if we wouldn't be able to be there in person. And I know that our care systems right now are really working diligently to give that, to help fill that gap. But now I hope that people will remember that they might also call upon the chaplain if the chaplain does not call upon them. So even if we just got that one little bit of information, and 30 minutes is about the length of this interview, and I know 30 minutes can be, it can be more than what people can stand, but hopefully even in this just first 12 minutes, we've arrived at, hey, call your chaplain if you get in that situation. There's a good chance that, and I think it's in part because your role is to meet people more at that human level. You don't have to work with all of the technology and the equipment, and you're not focused on the disease, you're focused on the person. And it's not that our other caregiver team members are not focused on the person. I don't mean to imply that, but that's your sole focus. And the fact that hospitals are wise enough to have that dedicated role, I think is really important for us to take note of. Let me turn our attention just slightly. This is a question that I ask most people when I'm interviewing them, and that is, when it comes to medical care safety, how do you talk about it at home with your own family members? Taking it out of the context of the professional environment for a moment.
Yeah, I think I've been fortunate that I have, fairly good health, but it is something my daughter and I talk about quite a bit. And, just the importance of understanding that, everyone is human. And sometimes, when we're in a vulnerable position, even people with the best of intentions can sometimes make mistakes, and that we have to be very mindful. We have to be very aware that we are part of a community, that we have a voice. This is something my daughter's 12, and this is something I'm teaching her right now, which is we have to sort of be authors and narrators of what we need and what we're experiencing. And that is part of what I see my role as a parent. But also in my role in the hospital is making sure that people's voices get heard, because, I am the one who inhabits this body. I know when something's not right. I know when I need help and care. I know what that looks like. And I think that's the most important thing I feel like I want to teach, and talk about in my own family, and certainly when I was caring for my parents and things like that, I was always at the hospital with them, and using my voice, obviously, but also really empowering them to speak up. Because if we don't have that kind of culture, things are going to happen. And I have tremendous respect for the physicians, the nurses, all the different members of the care team. And I will say many of them are trained to come in and be experts on the piece that they bring, which is very important, which we all need to hear. And part of what I love about being a chaplain is, we really are experts on, sort of the dynamics of what's happening, the feelings, sort of the existential, how people are making meaning of what they're going through. And that requires a lot more listening than it does talking. And so I am constantly saying to patients, have you shared this with your physician? Have you shared this with your family? Have you, and sort of asking these, open-ended questions like, what concerns you the most right now? What is most important for you? What gives you hope and strength? What are your fears? So that really we can draw out the heart and the wisdom and the sort of expert of the person who is experiencing this care. Does that make sense?
It does. It makes perfect sense to me. And one of the distinctions that I think could be made, and I will test this when I speak again with the next physician or nurse or somebody who's in more of a role to give prescriptions, is that it's a distinction that I think might be made, that you're not in a role to deliver to a person a diagnosis or to tell them about themselves, that your role is to draw out and help them find their own voice and then encourage them to use it. And I happen to co-chair with Marty Hatley, a very renowned advocate for person and family engagement, specifically related to hospital and healthcare safety. And I've learned so much from him, and I think have become a little bit of a subject matter expert, although certainly not the 25 years that Marty has in this field. And that is, we know there's good science, evidence-based research that shows us absolutely without a doubt that when someone can identify what's important to them and they can articulate that to their care providers, and then that care provider is able to listen and comprehend what is being said, the care quality, safety, the exchange in that relationship improves. So in a way, it sounds like part of what you do help facilitate that, starting with just asking those broad questions. What's important to you?
Yeah, we talk a lot about, when we're involved in family meetings, I sometimes say to families, being here, it's like you have to learn new language. We have a whole medical language that, for many people, they don't often understand what is being said. So I will sometimes say, if the physician is giving a very detailed and very important information, but I'll just pause for a minute and say, what did you just hear, or what do you understand? What do you understand is being said, and what are your questions? And I encourage families to take notes if they can. And sometimes after a meeting like that, or if they've shared maybe some struggles or challenges that they're having, I'll encourage them, like, well, write these down, and when your provider comes in next time, make sure you get to ask these, because I think sometimes people are intimidated by the system, or they know someone is in a hurry, or they it's just kind of exhausting too, to kind of have to take in all this information and process it. And sometimes I'll say, like, I think, let's give them a little time to just sort of take in what you've just said. And if they have to make a decision, we're not going to press them right now to do that. We're going to let them talk and sort of sit with this for a while. So those types of conversations, I think, are also really important.
They are. Uh, this is just a slight side road. It came up in my original conversation with you when we first met and were preparing for this interview. You mentioned something that had never occurred to me, and that was that in some hospitals and in some healthcare centers, the chaplain has an ability to influence the person's electronic medical record. You can make notes in there. Then, of course, then can get read by the next physician who is taking a look at what's going on. And you made it clear that that may not necessarily be true in every hospital. But I would love for you to think about the listener who might be paying attention to this interview right now and may find themselves even in a hospital right now, or want to prepare to be so, or have had the experience and want to be even a better advocate next time. Is that a question that might be helpful for someone to ask of their chaplain, just in terms of how would they form that question? What advice would you give them to find out what kind of role and what kind of influence their chaplain has with their healthcare?
Yeah, I think that's, I'm just making sure I understand the question. Are you sort of asking how I use the medical record, or what I document that sort of supports this safety? And is that?
Give us, I think it would be helpful to have an example, and then also
Yes.
thinking through
Okay.
the lens of somebody who wants to be a great advocate at wherever
Yes.
possible, whatever hospital they're in. What might they ask of their chaplains? How might they try to utilize
Yeah.
that role?
Approach that. Yes, that's very clear. Thank you. Well, I'll tell you, uh, in terms of documenting in the interns do read our notes, because we tend to be able to tell, we tend to use a lot of the patient's own words, and we also tend to sort of paint a full picture of this person. So many times people come in and they're seen as just what they're there for. So if they've had a heart attack, or they're having they're receiving chemotherapy, they're having a knee replacement or whatever, and we really want to get we want to have the full picture of this person's, sort of a more three-dimensional, what is this person like? What is important to them? What are their relationships? All those types of things that really humanize kind of who we are, and who we are as individuals, and sort of what our preferences are, what's meaningful and important to us. So, in some cases it may be a spiritual or faith identity, but a lot of times people will share that the reason they really want to do their therapy is so they can get back into their garden, or so the notes that we write sometimes help the other members of the care team, one, make a connection also with the patient, but also just to know what's important to them, and to sort of see them in their fullness, for lack of a better word. Because again, we have time, we have the luxury of time, where many of our care providers don't. They have very clear tasks that they have to do in the time that they have. There was one study that showed that the person who stays in the patient room the longest number of minutes is the environmental services worker. And that EVS, sometimes learns things about patients and families that no one else on the team knows, So I can think of another example where a patient was like, didn't want this particular procedure that the doctor was really recommending because she was afraid it would keep her from going to a family event that was really important that she wanted to do. And why she didn't share that with the doctor, I don't know, but I was able to share that information. So it's sometimes just asking the right question to get at something like that. So I would say for advocates, the other piece that's so important in our work is there's been a big shift, from sort of patient-centered care to really family-centered care, because it really is a family unit. As you know, that is experiencing this health situation, whether that's a crisis or not. But it's really treating the whole family because of the web of relationships that we all have. And I would just say to people, call if you. We can be very strong advocates. We also kind of know the system. So we know who we can go to. If someone needs, a certain type of, sometimes it's a little even thing as like advocating for a kosher meal or something that might seem so simple. But sometimes family members or advocates run up against, a wall in the system. We talk a lot about, pain. Everyone who comes into a patient's room, can do a pain assessment. So we can see like, oh, I see that you're experiencing discomfort. Let me talk to your nurse. Maybe, you could share with him or her what's going on so they could, try to address it. You probably don't, maybe you don't need to be in that level of pain. So yeah, I would definitely encourage advocates to call. I think we have this, some people have this idea that we're somehow, the Grim Reaper, or we're only there if people have a particular religion or faith, and we do address those needs. And we also really see people's experiences more through a spiritual and existential lens. That's part of our training. So we meet people where they are and we ask what's important for them to support them. Yeah.
I want you to know that if my eyes are darting off, it was because we were having just a little bit of a lag here, and I wanted to make sure that I had everything turned off that I could to get the best internet connection as possible on my side. So I apologize. I was listening intently, and I was trying to make sure that we had a good clean feed here. You just mentioned something that I think, I'm not going to put this on you, but if you want to add anything to this, I would welcome it.
Okay.
In the experience that I had with my husband, Yogiraj Charles Bates, and just for those who are listening who don't know the full story, I can give you a 15-second synopsis. Went into a hospital for one reason. That particular issue was resolved. Developed a hospital-associated venous thromboembolism, had very clear signs that that was going on, and 13 days later died from that hospital-associated event. And what you just said has me want to convey to administrators of these systems. That was the first time. It was basically as he was dying from the pulmonary embolism that I first saw a chaplain. That it was, and a chaplain was sent to our side. It was not something that I thought to ask for. Now, my husband was a very spiritual man. In fact, he was ordained as a Hindu priest. And so, and everybody knew that he meditated every day. It was very well known. After 13 days, people get to know us, and they knew I wasn't leaving his side, and that we had our important spiritual practices. It never occurred to me to call a chaplain. It was never suggested to me to call a chaplain. And then suddenly, in those final moments, a chaplain, in fact, two chaplains were sent to our side because we had family members and they needed to be attended to as well. And thank goodness they were there. They were so delicate and responsive and helpful, genuinely helpful, both from a practical matter, but also a spiritual matter. Here's my wisdom for any administrators who are listening is don't let that moment be the first time that your patients or family members are introduced to a chaplain. And it sounds to me, Carrie, as though you work within a system and advocate for the chaplain to be a role from the point of care rather than the end of care. And I can't tell you
Mm.
what that would have meant to us if that hospital had ensured that. So do you want to add anything to that? I don't want to put you on the spot, but
Um, no, I really appreciate you raising that up. And I think the only thing I would add is in many hospitals, at least where I worked here in Northern California, chaplains, we're very involved in the daily rounds that happen. So we're in our ICU rounds every day so that, and we will report in as, when the dietitian or the pharmacist or the social worker we'll sort of also, give our update, and because we are a patient family-centered facility, the family is encouraged, obviously, to be vocal and participate in those rounds, and so they also then become aware of our role as part of the interdisciplinary team, and we do follow up, especially in our intensive care areas, but also, in the other areas. So I do appreciate that. And I've I feel fortunate that I've worked in health systems that where the chaplain's role is very well integrated into the care team, and that it does make a big difference.
thank you.
Thank
So
you.
that would be a question that I would suggest to
Mm,
people who are thinking or wanting to plan for or be prepared for the unexpected moment when
yeah.
they find themselves, they end up in a healthcare system is to invite the chaplain in.
Hmm.
Let's turn for a moment, if we could,
Hmm.
to the prioritizing safety part.
Yeah.
I'm really curious about your role in that regard. You mentioned it briefly at the beginning of our conversation here. And I'm particularly interested, Carrie, in two aspects. One is what kind of support have you been able to lend to families like ours in those
Mhm.
moments? And I can see it was
Mhm.
meaningful for us,
Mm.
but also, and maybe even as importantly, well, I feel as importantly, that's just my humble opinion,
Mhm.
it's the support for those care providers,
Mhm.
for those nurses and physicians, and even I'll tell you, there are two people who come to my mind who I know for sure would have been very, very moved by the fact that my husband died after those 13 days. One was the transporter. And I call
Mm.
his attention to him because he was often the person who showed up to help wheel Yogiraj from one appointment to the other. And
Mhm.
on the second to the last day, which happened to be Father's Day, he noticed that all of a sudden there was this appendage of a, a oxygen tank that now needed to go on the wheelchair. His noticing of that, he mentioned it. He was that attentive. The second person was the first person who came in to help my husband get out of bed and take a few steps after
Mm.
his initial brain surgery. She and he and really me too, we developed a bond over those few
Mm.
days. I know that a spiritual conversation with whoever it was in that hospital probably would have been welcomed by them as well.
Yeah.
And I don't know if that happened. I rather doubt it in that particular hospital at that
Mm.
particular time. Maybe today it would have. Speak to us about your experience there. What's possible from
Mm.
your perspective?
Well, in terms of supporting the the staff after an incident like that? Is that
Yes.
um,
And the family
well,
members and patients if they're harmed.
yeah, yeah.
Everyone.
Well, I think um, the first thing I would say, there's two things I would say. Being a non-anxious presence in a time of just severe anxiety and just emotional crisis is one thing that's just very important. And as you said, kind of tending to some of the practical things, like, you know in a very intense grief experience, making sure people have a place to sit and they have water, and that people, because in a crisis like that, you know our reptilian brain, we're not functioning at our best when we are experiencing that trauma. So being attentive to some of those, basic human needs is important. Certainly, I think we, again, going back to that, the two pieces that I said about sort of like, these are what I call these threshold moments that people are going to remember for the rest of their lives.
Yes.
And we can't take away the pain of these moments or the trauma of these moments, but we can tend to the emotional and physical and other, sort of responses in a way that comforts and normalizes and just kind of helps make sense, and not make sense, that's the wrong word, but just kind of helps people get through it and process it. And that goes for the loved ones and family members, as well as the staff. So we do debriefings, we do rituals, we just sort of keep silent too, and make space for people to feel whatever intense emotions they're having, and normalizing those responses. I like to also think of what we call, you've probably heard this before, but sort of the platinum rule. The golden rule is that we do unto others as we would want them to do unto us. But really, I don't, what I might need in a situation like that might be very different from what someone else, might feel as supportive and comforting in those situations. So we really, again, it's the platinum rule is do unto others as they would have, me to do to them. So that's where that relationship is really important. If we've had a chance to interact, with the family before, if there's a critical incident, the support for the staff is, I have to say, I feel like the biggest piece that we do is just a lot of one-on-one listening and giving staff permission to cry. I mean, I was recently at the hospital, and it was a difficult death. It was a COVID-related death, and it was a young person, and the physician was crying, the nurse was crying, the RT was crying, because these losses, even though they're not our personal losses like they are of the family members, they do, remind us of our own vulnerability, our own mortality. We say, and they bring up other deaths that we've experienced, of our own loved ones. So, just again, helping people to express those feelings, and like, it's okay to cry. It's not a sign of weakness. I always say, when any about, tearing up or crying, I say, grief is a sign of love. It's a sign of love. It's not weakness. It's loss means that we love deeply, and that's beautiful.
Well, that is a beautiful place for us to conclude. I hope that you might be willing to follow up with another interview at some point because I have more questions, but I
Yeah,
also know the typical tolerance of a viewer, and about 30-35 minutes is already kind of a stretch. So
yeah,
I may we have a part two at some point if you're
absolutely,
willing to
sure.
do that. I think
Yeah,
there are
very much
some,
so.
maybe as I get closer to Capitol Hill, because one of the places, and I'll just put the seed, I'll plant the seed now so that we get there, is I wonder what it will take to help the legislators really become part of that care team.
Mm,
And I think that COVID has actually created that bridge. We're deeply impacted emotionally, just human to human right
yeah,
now,
yeah.
and recognizing all of the sort of vulnerabilities that our healthcare system has right now, whether it's about equity and access, or how to
Yeah,
provide the highest priority around safety,
yeah.
or giving people those opportunities to have their physical bond present at those
Mm,
important transition times of birth and death and pain and suffering. There's a long, long list, and it's my anticipation even that by the time I get to Capitol Hill in September and I'm sitting in those offices with our legislators, that this won't be news to them, that they will have had their
mm,
own cathartic experience and maybe even had their own opportunity to take that
yeah.
platinum approach, which,
Mhm.
as you so eloquently articulated, it requires us to get to know the other person.
Yes.
And if there's nothing else that we accomplish with the attempt to help our systems, whether they're long-term health care or rehabilitation or acute care or
Right.
EDs or what have you, that it is just really that even if you're not a chaplain, there's an invitation to really get to know those who are giving you care, get to
Yes.
know those who you're offering care to, get to know those who are creating the environmental cleanliness of your space,
Yeah.
making sure that the tray of food has what it needs, just every little detail there is so
Every,
important.
absolutely every, and all of those things do point to safety and wellness because it's the little details and it's the observant, transporter or the observant, dietitian or, who's like, or those, all those things make a difference. Yeah, I'd be delighted to speak with you again, Fonda. I'm excited about your journey, and yeah, I think COVID has really exposed, so many opportunities
Yes. Yeah.
in our system.
And, may we with our a full ability and presence and heart really
Mhm.
step into those potentials and make the improvements that we know are essential, not just because of COVID and not just for the future, but also to honor all of the lives not who have suffered in some ways,
Mhm.
those alive and those not living, who have helped us understand how important this topic is. Carrie, thank you.
Thank you, Vonda. I really appreciate the opportunity.
And thanks to those who have listened to this amazing conversation. I'll look forward to the next time. And if you'll stay on for just a moment, I'll stop the
Yes,
recording and we'll just do
yes,
a couple of follow ups. Thanks
great.
again for listening, everyone.